as well as them having regular clinic visits. It's the most effective behavioral intervention for this group. Unfortunately, couple-level prevention programs have not been widely incorporated into global prevention campaigns. In Africa, for instance, we have less than 1% of couples that have been jointly tested for HIV. So in Nigeria, where this study was conducted, the last HIV Sentinel survey of 2010 reported a prevalence of 4.1%, which was a slight drop of 0.5% from the 2008 Sentinel survey. However, we still have a high burden of disease because we have, in terms of absolute numbers, we have about 3.5 million people infected because of the high population of about 160 million people, making us second to South Africa in terms of the disease burden globally. So in Nigeria, we have a range. You have as low as 1% in one of the states to as high as 12.7% in Benue State, which was the state in which this study was carried out. The hospital, because it was a facility-based, the General Hospital in Otukpo is a local government in Benue State. It has one of the largest HIV/AIDS specialist treatment clinics, and it's been sponsored by the Institute of Human Virology in Nigeria, so they are able to give comprehensive HIV care. So what we decided to do was to determine the proportion of HIV-positive patients who had disclosed their status to their partners, and then also to determine the proportion of HIV-positive patients whose partners are also positive and attend the same treatment center. When tested in the same treatment center, because we wanted to see, them receiving care as couples as opposed to individuals, and then also to determine the factors influencing same clinic attendance by HIV-positive partners. So what we did basically was a descriptive cross-sectional study. The study site, the facility, as of the time of the study, had about 1,500 registered HIV-positive patients receiving care. And we decided to look at HIV-positive patients that were age 18 and above with a confirmed seropositive status and were registered at the clinic. We calculated sample size, we arrived at 270, and we used systematic sampling method to select our participants. And we now had trained interviewers who asked them questions using a structured questionnaire that was developed during literature search. So the highlights of the results, at the end of the day we analyzed 261 valid questionnaires that were accurately filled. The mean age of the respondents was 35.6 years. Most of the respondents were female, 52.5%. Most were married, 46%. Most had secondary education, 44.4%. And most of them were self-employed. We also briefly looked at the sexual behavior and disclosure status of HIV status amongst respondents. Among them, those that had sexual partners, 77.4% had sexual partners, 71.6% were currently having sex, and when we asked those that were currently having sex about the use of condoms, 94.1% said they were using condoms. However, we did not go further to ask, about frequency of condom use, timing of condom use, etc. So we found that among those that had sexual partners, only 20.8% of them had disclosed their status to their partners. And then reasons for this were majorly fear of being stigmatized. They didn't want to be treated differently in a negative way on account of their HIV positive status. some reported not trusting their partner with that kind of information. There was also fear of separation. Some were waiting for the right time before disclosing their status. So in terms of the partner's clinic attendance, 89 of the respondents, that's 44.1%, of the respondents who had partners knew their or reported their partners to be HIV positive. And then 38 of the HIV positive partners, accounting for 42.7% of this subgroup, did not attend the same antiretroviral clinic with the respondents. And the major reasons were fear of stigmatization, attitude of the health workers, inconvenient clinic time, smaller proportions mentioned high cost of transportation, some were in denial, others had preference for other centers, distance, and then some small proportion were trying an alternative means. The partners were trying alternative means of treatment. So we did, some bivariate analysis with some variables and positive partners, attendance of same clinic. And what we found that was statistically significant was that living together, cohabitation, actually about 69.3% of the respondents whose partners, with partners were living with them. But when we looked at this bivariate analysis, we saw that a higher proportion of those that were cohabiting or living together with their partners had their partners attending the same clinic with them. So we compared our findings with a few studies, and we found that though our disclosure rate was low, it was still higher than a few African studies. Specifically, we compared with rates from a study in Burkina Faso, West Africa, and the Niger Delta region in Nigeria. Ours was still a bit higher, maybe because of the national campaigns and support groups advocating for HIV control and awareness. So reasons for non-disclosure in our studies were similar to a study in London. And then we also found that in another study in the US, stigmatization experienced by people living with HIV also resulted in poor access of HIV care there. So despite our gains with HIV care, prevention, and control, we find that fear of stigma still remains an important factor, influencing both disclosure of retroviral status as well as couples' attendance of antiretroviral clinics to access the much needed care and treatment. And we recommend, that couple-level prevention programs should and must, be incorporated into HIV prevention strategies in terms of policy action. And then, of course, we need to address stigma. When we want to reach out to policy, when we want to reach out to couples, we need to address the issue of stigma. Stigma is rooted in fear and ignorance. So a lot of health education needs to be put into place and to correct myths and misconceptions. And focusing on couples, also especially in our area, would improve male involvement, because we find that most women are the ones who, most times women are the ones who know of their HIV status first when they're going for antenatal care. So when we look at couple prevention, we are able to have better control. Also in terms of integration, we know that, especially what we heard today in the short movie that we saw, the one-stop shop video. If we want to achieve effective integration, we have to look at couples. The video showed us, a man and a woman together expressing their own, impression, good impression concerning integration. Okay, so when we can do that, we can improve also the standard of love among couples living with HIV. So these are some of my references. I wish to thank you for listening to me.
Thank you very much, Dr. Mobolanle. I wish to introduce our next speaker, and he's called Ahmed Burai. And Ahmed is the Senior Program Officer with the Afia Plus program, and which will be talking about the program's work in the northeastern